Hi, welcome to this presentation on submassive PE and the best approach to treatment. I'm Emma Spencer, I'm a Senior Specialist Practitioner in Resuscitation and Critical Care. In this presentation, I will examine the evidence on this controversial topic, weighing up the balance of mortality risk from deterioration with the risks associated with treatment. So let's look deeper into this subject and decide what would we do when a patient presents to ED who is tachycardic, tachypneic and has chest tightness, just like our friend Dave here. This is Dave, and after a full workup, we established Dave is normotensive, but with mildly elevated troponin. The echo shows he has some mild right ventricular dilation and hypokinesis, and a CTBA confirms he has an acute PE. He meets the European Society of Cardiology's criteria for a submassive PE. So what are the options to treat Dave, and how do we decide which one is best? We have 1. To anticoagulate with IV heparin, 2. Administer a systemic dose of a thrombolytic drug, or 3. Attempt an endovascular approach, aka mechanical thrombectomy. However, the risks involved with the invasiveness of a surgical procedure against the mortality factor of a submassive PE are considered too high at this point. So, what evidence is there to support our decision making? There are scoring systems to help calculate the mortality risk from PE, helping to guide our decision making and how aggressively to treat. The PESI score is a useful addition to our armoury, along with lab results, radiology input, clinical observations and clinicians' judgment. Firstly, let's look at anticoagulation. Anticoagulants do not dissolve the clot, but instead halt the spread or growth of the existing thrombus and let the body's own fibrinolytics do the job. It's low risk for bleeds, but not completely risk-free. It can achieve long-term results in 70 to 85% of patients with submassive PEs. This sounds good, right? However, that leaves 15 to 30% of patients with potential unresolved thrombi and possible post-PE syndrome. This is an issue. So what other options do we have? Let's look at the PITHO trial. In 2014, Meyer et al. Conducted this double-blind trial of 1,006 normotensive patients with an intermediate risk PE. The population was randomised into Arm 1, who received tenecteplase, and Arm 2, a placebo, both groups also receiving an anticoag. Their follow-up after 30 days found patients who received tenecteplase had a lower risk of deterioration or collapse in the first week. However, there was significantly more major bleeding, be it intracranial, extracranial or stroke. It was all seen in the tenecteplase group. So despite Pytho being the Greek goddess of persuasion, Meyer et al. Don't do a great job of persuading us to jump to the thrombolytics. There are issues with this trial. The first being that clinical follow-up was only available for 62% of the surviving participants. Are the ones who had the placebo struggling with long-term pulmonary hypertension, or alternatively are the patients who had the tenecteplase doing brilliantly and are fully fit and well? While the authors have clearly outlined the definition of submassive PE, they include patients with an elevated troponin in that criteria. So what? Well, this means that their population is perhaps at a higher risk, and this can skew the results either way. Another problem is that the anticoag was administered as well as the tenecteplase. Therefore, any bleed could be attributed to either drug, not just the thrombolytic. And interestingly, a longer-term follow-up was performed 2 years later, and they found no significant difference in mortality between the two groups. This does not bode well for a risky treatment that perhaps the patient might not have even needed. So, what about giving a lower dose of thrombolytic and seeing what happens? Say hello to Moppet. The Moppet trial looked at the pulmonary artery pressures of patients with a submassive PE and whether these pressures were reduced with the so-called safe lower dose of tenecteplase, namely 50 milligrams plus an anticoag drug compared to an anticoag alone. They randomly split 101 patients between the two groups. Their findings showed a significant difference between the groups. Adverse higher pulmonary artery pressures of more than 40 milligrams of mercury were seen in 57% of the anticoag-only group, compared to just 16% of patients who received tenecteplase. And amazingly, there were no major bleeding events in either group. The authors concluded low-dose thrombolysis is effective and safe in the treatment of moderate PE. So, are these findings reliable? The trial was only performed at one centre with a small sample size, meaning it was underpowered to determine differences in mortality. Also, the confidence intervals were not reported, therefore we are unable to fully gauge the significance of the findings. Again, their criteria for submassive PE is brought into question, with only 21% of patients having right ventricular enlargement and 6% having hypokinesis. So what? Well, this means that the included population may be lower risk than other similar trials, positively skewing the results. Plus, the reduction in pulmonary artery pressures in the thrombolytic group only decreased by an average of 15 millimetres of mercury. So is this actually clinically relevant? Interestingly, the dose of 100 milligrams is unsubstantiated. There's no supporting evidence of why that particular dose was chosen to treat PE. Kaiser et al. In 2018 also observed this half-dose alteplase in a cohort of acute PE patients, comparing it to a full dose. After propensity matching, 46% of patients treated with half-dose therapy did not require further intervention. However, they did see similar mortality and major bleeding rates in both groups. This study did not have a very clear method differentiating between low, intermediate or high-risk PE patients, and they were also unable to measure the long-term outcomes, which is a real problem in recommending this treatment. So, if systemic thrombolysis is risky, be it full or half dose, and it doesn't improve mortality in the long term, then what about an endovascular approach? Step up the interventional radiologists. Mechanical thrombectomy is an endovascular catheter approach where the thrombus is broken up with a pigtail or balloon device, which then can be suctioned out. On the face of it, mechanical thrombectomy seems an attractive treatment option. The FLARE study, published in 2019, evaluated the FlowTriever system in patients with intermediate risk PE. After looking at the RV-LV ratios and adverse outcomes in 106 patients who were treated with this device, the authors concluded that this system appeared safe and effective, with significant improvement in RV-LV ratio with minimal bleeding seen. This sounds excellent, doesn't it? But delving a little deeper into the FLARE study, they excluded patients with any bleed risk, and the study is non-randomised, essentially meaning they have carefully selected their population. Also, they have no comparator arm to contrast against, and the follow-up time was at 30 days, limiting data to short-term outcomes. Not the most helpful. Many of the studies looking at specific devices have a population of acute PE patients only, so the balance of intervention risk versus mortality from PE is largely in the intervention's favour. It's procedurally complicated, and the risk of cardiovascular compromise means experienced practitioners are always required, making it a relatively risky treatment option. To try to make sense of all the studies and trials that there have been on this subject matter, several systematic reviews and meta-analyses have been undertaken. This spectrum of severity of PE that were included in the trials could have skewed results one way or the other, as severely ill patients would need a more aggressive treatment, but would also have a higher mortality risk from PE. Marty et al.'s systematic review summarised that despite thrombolytic therapy reducing total mortality and PE-related mortality in patients with acute PE, the risk of major and fatal or intercranial hemorrhage outweighs the benefit in submassive PE patients. Also, Igneri et al. Evaluated the safety and efficacy of thrombolytic therapy for both massive and submassive PE. They concluded saying anticoagulation should be the first line, but if any deterioration occurs, they suggest we reach for the thrombolytics. So let's weigh it up. Should we anticoagulate with heparin? It provides a low bleed risk, it's uninvasive, it can improve symptoms, but it can leave unresolved thrombi, which may lead to post-PE syndrome, and there's a risk of deterioration. Do we thrombolyse? This carries a major bleed risk, which can be fatal, with no proven long-term mortality benefit. So why risk this option when the patient may not have even deteriorated in the first place? However, there are proven results of reduction in clinical deterioration, and is this not our aim in ED? Or do we opt for mechanical thrombectomy? It carries serious procedural complications. However, on the flip side, RV dysfunction is significantly improved, there's a lower bleed risk, and it reduces the need for post-procedural hospital stay. Also, advancing techniques with catheter-directed lysis is a possible future option. It's all about risk stratification, and so how would I treat Dave? My process would be to look at Dave's symptoms and vital observations, calculate a PE severity index score, consider the radiology report on clot burden and position, consider the biomarkers, lactate and gases, assessing the risk of deterioration, and I would look closely at the RV-LV ratios and pulmonary artery pressures. So, if symptoms and RV dysfunction were mild and biomarkers and lactate were within range, and if radiology confirmed the clot burden wasn't overly occlusive, I would opt for an anticoagulation treatment, monitoring for any deterioration over 2 to 3 days, knowing we can always escalate if needed. However, if Dave had elevated biomarkers and his RV strain was worsening and he was at the point of possible collapse, I would use a bleed risk score model for intracranial hemorrhage, such as the one devised by Chatterjee et al., and as long as there was no contraindications to thrombolysis, I would administer an IV infusion of half-dose alteplase, namely 50 milligrams over 6 hours, and I would monitor his RV-LV ratio and PA pressures, alongside close monitoring for hemorrhage or any coagulopathy. So, the key messages. When looking for the best approach to treat a submassive PE, we individualise and risk stratify as best we can. We use clinical, radiological and lab results to guide our therapeutic decision making. We should choose a treatment option with the least procedural risk, but has the most benefit for reducing RV dysfunction and for long-term outcomes of our patients. So how is Dave doing? Well, Dave was managed well on the alteplase, and he went back to living his best life with no long-term symptoms and spending time with his family. Thank you for listening.